Hello everybody, my name is Fernando Aleman. I am an international medical graduated from Nicaragua, UNICA University. This is my second YouTube video that I am uploading to my recently created YouTube channel. This is a very important video for me since I'm going to be discussing my second favorite bug of all, which is Clostridia. It's my second favorite bug and is a very high yield bug for the USMLE Step 1. So I'm going to be uploading a series of videos in which I'm going to be discussing the different strains of the Clostridia family, and I'm going to be explaining the most high yield details or topics of each and every single one of the strains. So yeah, into this video I'm going to be discussing this first one, and I'm going to be uploading more videos about this Perfinges, Tetani, and botulinum. I'm going to be discussing today Clostridioides difficile. So talking about some Clostridia general principles, some basic features of the Clostridia species, we know that they are gram-positive bacilli or rods. They are spore-forming organisms, and they are obligate anaerobes, right? We can find them in soil and fresh water, and also in the intestinal tract of human and animals, and this is very high yield in order to know the virulence factors of some strains of the Clostridia family. And the spores can be airborne as well, and we can find it on cervical vaginal flora. So the infection by Clostridia families can be exogenous from the outside or endogenous from the inside of the body. Let's keep in mind that we can find them in the intestinal tract of humans, of ours, okay, of ours, in our intestinal tract. And the disease can be caused by exotoxins or enterotoxin productions. There are 50 plus known species of the Clostridia family, but the common known human pathogens and the most high yield for the USMLE Step 1 includes Clostridium perfringens, Clostridium difficile, Clostridium difficile, which was reclassified and now is known as Clostridioides difficile. Clostridioides difficile. There are a lot of ways to call it. We have Clostridium tetani and we have Clostridium botulinum as well. So on my Instagram, I recently, a few days ago, I posted a image that I made about the classification of the gram-positive bacteria. Keep in mind that the Clostridium is a gram-positive bacteria, and this is a more specific, a more detailed classification about the gram-positive, specifically about bacilli, in order to understand about Clostridium. Okay, so we have the bacilli or rods. Whenever we're speaking rods, we're speaking bacilli, right? So we have the bacilli is spore-forming positive, catalase negative, and we have Clostridium. And then they can produce, or they can't produce, a neurotoxin. If they can, will they produce an open boro neurosign? Yes. We have Clostridium tetani. No. We have Clostridium botulinum. If they don't produce this toxin, are they motile? Yes, they are. We have Clostridioides difficile, and if they don't, we have Perfinges. So this is a detailed classification in order to understand the Clostridium family classification as well as it is said per se. So in today's video, I'm going to be explaining Clostridioides difficile, also known as C. diff, or as I prefer to call it, C. difficile. I prefer to call it that way, which is my favorite strains of all Clostridium family, by the way. So talking about some general principles, we have in here all intestinal. Well, first of all, we have the C. difficile is a gram-positive bacilli, catalase negative, spore-forming obligate anaerobe. Okay. So in this image we have in here, we have on our intestinal, or intestines, and we have these purple dots that represents to C. difficile. So we have C. difficile, C. difficile, C. diff, C. difficile, C. diff, right? And we have these other greenish and red dots, which represents other bacteria. So what I have to what I mean is that C. difficile forms or microbiome. It forms part of our natural microbiome of our human body, plus other bacteria that we have in here. But the most important thing is that these other bacteria, these red and these green dots, are in charge of holding back C. difficile. You can see that C. difficile live in our body, but we do not have any symptoms of C. difficile because these other bacteria that are holding the strains of C. difficile. Okay, so if by any mechanism we get rid of this bacteria, or we only leave C. diff in our body, we are going to present some symptoms, some acute infection for this C. difficile, right? So this is very important to know. This is ideal as well, and I was just being clear about it. So we know that C. diff colonize our GI tract, and the transmission is fecal oral. Some so C. difficile can go out in stools, and they can get into the soil, and then if we don't wash our hands, it can get into us, and it's a cycle, you know. So that's the way it can be transmitted, and how this cause the symptoms. So C. difficile have two toxins. We have toxin A, which is an enterotoxin, and these bind to the brush border of the enterocyte. We have in here, or this image describe our enterocytes. So this enterotoxin bind to the brush border of the enterocytes, and it also inactivates the rho family protein, which causes the damage to the apellar junctions, and it will increase permeability. So we have all the enterocytes in here. We have the rho family protein that are in charge of keeping very straight, very together our enterocytes, and then this toxin A come in here and inactivate this protein, and our enterocyte become become loose, and they leave some dead spaces in here, and we have in here our capillary, and we have in here interstitial fluid that will go through these gaps that this enterotoxin A causes. Okay, so we have our gaps in here, and all the interstitial fluid will go through the gaps, through the dead spaces, which will cause an increased epithelial permeability, which will produce as watery diarrhea. So we have also a toxin B, which is a cytotoxin, as we can see in here. This cytotoxin is going to bind as well to the enterocytes, and it will disrupt or cytoskeleton of the enterocyte. It will break down, if we can call it, the enterocyte, destroy, if you want to call it. And because of this cytopathic toxin, so this toxin B will destroy the enterocyte, will break down the enterocyte, and this will cause inflammation. And we have some cells in the capillary. We have the neutrophils that is going to be like, oh, you know, there is some inflammation. The neutrophils are going to say, we have some inflammation in here, we should go take a look. And they will go take a look in here. There will be a release of cytokines. Plus, the neutrophils are going to bind into the walls of this damaged enterocyte, and that will create a special appearance into the intestinal wall, some kind of fibrin membrane into the intestinal wall, which is kind of the very high yield and classic presentation of C. diff infection, right? So we have we have the toxin B, we have the toxin A, we have the toxin B, and both of them are going to create a lot of damage to the enterocyte. They're going to create dead spaces, leakage of all the fluid, destroy the enterocyte. So it's a mess what these toxins can do. So just to recap, we have an enterotoxin A and then cytotoxin B, and I have this very cool mnemonic that I got. We have an enterotoxin A that bind to the intestinal brush border of the enterocyte. So we have and, and we have the cytotoxin B, which destroy the cytoskeleton. So this cytotoxin B, cytoskeleton destruction, right? So it's very important to know these two toxin of Clostridia of C. diff. I have seen some some question about C. difficile virulence factor on some Q banks, so it's very important to be clear about these two toxins. Okay, you can pause the video, you can watch the cytotoxin explanation, the toxin explanation, and from there you can move forward. There is no pressure in here. So, as I was explaining before, the neutrophils will bind to the cell to the enterocyte wall, and they will create fibrin, and this fibrin will create a membrane that is look like this pseudo membrane that is look like this, and this will cause C. diff pseudomembranous colitis. Okay, that's this name is given because of this appearance that is because of the action of the neutrophils into the enterocyte wall. So why? What are some risk factors for developing this infection? As I was explaining before, we, you know that we have C. difficile in our body, and we have other bacteria, and these other bacteria hold the strains of C. difficile from growing up, for growing up and damaging or provoking damage in our body. So whenever we are under some antibiotic usage, we can we can get rid of these bacteria that are kind of a protection for our body, and we will leave only C. difficile, and then C. difficile will grow up and will cause all the infection. So this illness, C. difficile colitis, is highly related to the recent use of antibiotic, specifically about clindamycin, and this is very high yield, and this is very important. Usually we can see the vignette that is describing a patient that was under antibiotic usage because of some illness, and we can start thinking that the question is going to ask us about that question. But then the vignette said that the patient is going back to the ER 2 to 10 days later with some watery diarrhea because of the usage of watery diarrhea. So when we analyze the whole strain, we see that patient used prior antibiotic. Usually, sometimes they can pull out with clindamycin, sometimes they don't. So we have to know patient was under previous antibiotic use, especially clindamycin. It can also be associated to penicillin, cephalosporins, or fluoroquinolones. And then this patient presents watery diarrhea. We have to think about C. difficile colitis. Also, is related to PPI use. Usually, this we can see in the stems about omeprazole. We can see I have seen some omeprazole vignette related to C. difficile colitis, and hospitalization because of obviously contamination, even though from some items from the hospital, or even from some items. You know, we are in that environment with a lot of contamination itself. So I just want to make this clear. I just want to be clear on this. So we have some damaged enterocytes. We have some watery diarrhea. Sometimes we can have a cold blood, and the examiners, the people from the steps, they want us to know the difference between watery diarrhea slash non-inflammatory diarrhea, and bloody diarrhea slash inflammatory diarrhea. So they want us to know this difference. I think that I will make a post about this because it's very high yield. Usually C. difficile cases, C. difficile vignette come with just watery diarrhea. I have never seen a C. difficile question or vignette when they say a cold blood, but you never know. Also, the patient are going to have abdominal pain and fever, and as we are having this watery diarrhea because we have more than three loose stools that we said. These can cause dehydration, and the patient can become dehydrated, and they will have a lot of consequences. So this is I was explaining before, this pseudomembrane that we see here in the enterocyte is caused by a C. difficile infection, because we can have recurrent infection, which I will explain furthermore then. So yeah, it's important to know this dehydration that the patient will have from C. difficile infection. So this is a very actually is a very serious infection. Clostridium difficile infection is very hard to treat, and the consequence it can lead to death actually. C. difficile infection. So it's very important. I mean, not about just speaking about the steps and also you about the steps, but is a very complicated infection. So you won't be thinking about, okay, it's just the diarrhea. It doesn't matter. We can give the patient fluids, blah blah blah. But actually not. I mean, it's very important to approach correctly to the diarrhea. Is something that we see a lot. It's something that we see a lot. We have seen a lot as medical students, and sometimes the approach to the diarrhea is not the correct ways. So as I explained before, we need to see, okay, is it inflammatory, is not inflammatory, should we give antibiotics, should we not give antibiotics, um, what happens if we don't make the correct approach, if we don't treat this C. difficile infection, it can progress into a fulminant colitis, which is caused by severe hypovolemia. I explained that watery diarrhea can lead to severe hypovolemia, which can lead to shock because of hypoperfusion, and this can lead to prerenal injury, and also to shock liver because of the hypoperfusion that we have in our entire body. Actually, the patient can present also abdominal distension. This is very important, and very high yield. This can cause toxic megacolon, which can advance as a colonic perforation, and this infection, this fulminant colitis, can also this C. difficile infection can also uh, be presented as a paralytic ileus. So what's going to happen in here? Let's imagine that we have in here an intestinal lumen. We have the dots. C. difficile is going to be producing toxin A, toxin B, which are going to destroy this wall, and we are going to have some water incoming into the intestinal lumen. We are going to have some neutrophils coming to the intestinal lumen. We are going to have some cytokine release. All this damage, all these cytokines are going to provoke the release of nitric oxide, and all these factors, all these processes, all these factors are going to provoke that the intestinal lumen are going to provoke edema, and the intestinal lumen, my apologies, is going to get bigger. Is going to get wide. So this intestinal lumen is going to get wide, it's going to get bigger, and we are going to have a paralytic ileus by this, because the motility of the intestine is going to be decreased, because it's so big that it can move anymore, and if it gets bigger and bigger, it can pops up. As we can see here, it can pops up, which can lead to the colonic perforation. So we can see in here some toxic megacolon. We can see here the transverse colon, and in here we have the decreased colon. We can see it looks flat. I mean, this looks flat for a colon. We can even see the ostrus in here. So it's super flat, and this is a toxic megacolon. Okay, so this is very important. This is very important because, as I explained before, C. difficile infection, if it's not treated properly or in early stages, it can have some serious consequences. So the diagnostics, we have different diagnoses. Usually, the gold standard is the NAT, NAAT, nucleic acid amplification test, as it is, which uses PCR to detect toxin-producing genes, so it's highly specific and is highly sensitive. But if we get asked in the vignette about the most specific test, we have the enzyme immunoassay, EAI. So practically this test will detect a toxin or a antigen. But the major problem of this is that we will need a very high quality and quantity of the toxin, so we can detect it. So that's a problem when we are talking about these tests. And then we have the third one, that is the enzyme immunoassay for glutamate dehydrogenase which is highly sensitive but is poor specific. And let's remember that not all the Clostridian species produce toxin. Okay, there are some Clostridian species that do not produce toxins. So yeah, if we are some what we can do in is we can first of all order this exam. We know that there are some genes produces, and we can then order this one so we can detect the specific toxin. We are know by this test we know that there are some toxins that are being produced, and by this test we can get to know the specific test. Okay, so we can order these two. The gold standard is this one, the most specific is this one. In the blood panel we can see leukocytosis, increased lactate because of the damage hypoperfusion that is being caused by C. difficile, and we can see increased creatinine because of the hypoperfusion into the kidneys. Also, in the colonoscopy, we can see the pseudomembranes that overlays the colonic mucus because of the neutrophils invading or attaching to the enterocyte wall. But we might be careful with this because we don't want to perform a colonoscopy in a person with a metacolon because we can perf that colon. So this is not usually performed in patients with acute infection. So the management, I know that the step one is not a lot about management, but really I've seen question about the management of for C. difficile infection, and I'm sorry, and it's high yield, it's super high yield. At first, we need to know the first line of for treatment. So we have all those patients. We can divide this in the patient that have the first episode. We have two options: either oral vancomycin or oral fidaxomicin. The gold standard, I will need to keep that. The gold standard for C. difficile is oral fidaxomicin. That's the gold standard treatment for C. difficile infection. Then we can have oral vancomycin if we don't have oral fidaxomicin. I remember actually when I was in the hospital, I saw a patient that was under oral vancomycin. I didn't understood very well. I thought that the plans were wrong, but then I realized that the patient was with a C. difficile infection. So yeah, oral vancomycin can be given for C. difficile infection, but the first choice is oral fidaxomicin, and this is a mnemonic that we have in here. Very first episode, very V for vancomycin, first F for fidaxomicin. So this is for patient that we have or in a first episode infection. We have patient that have recurrent infections. We will give fidaxomicin always as the first option, and if we don't have fidaxomicin for recurrent infections, it will be rifaximin. Okay, so this will be our second option or second resource if we don't have fidaxomicin available, and we have also a very cool mnemonic here: future recurrence, F for fidaxomicin and R for rifaximin in here. And metronidazole is our last resource for C. difficile infection. Actually, I came across with a question about C. difficile infection, and I didn't saw vancomycin, fidaxomicin, or rifaximin on the answers, on the options, and I saw metronidazole. I remember this question very well because I was confused at first. I thought that this question might be wrong. There is something wrong here. But no, the question was metronidazole is the last resource, and we can have fecal microbiota transplant for all those patients that have the microbiota full of C. difficile. So, well, yeah, just for us to know, but this is out of the scope for step one. So let's finish this video with a question in here. This is a normal question about, so let's read it. We have a 54-year-old male, let's say, present with fever, abdominal pain, nausea, and watery diarrhea. He said that his symptoms started 36 hours ago and have not improved. 2 days prior, he developed a small leg abscess secondary to an injury sustained from a fall. He underwent incision and drainage of the abscess and was started on oral clindamycin. Past medical history is significant for gastroesophageal reflux disease, for which he has taken omeprazole for many years. His vital signs include temperature 38.5, respiratory 19, heart rate 90, and blood pressure 100 over 70. So enzyme immunoassay testing confirmed the diagnosis. Which of the following is a more appropriate treatment option? We have option A, ciprofloxacin, option B, ceftriaxone, option C, fidaxomicin, option D, we have erythromycin, and option E, we have permethrin. So you can pause the video, think about the options that I gave you, and let's go. Okay, so we have in here some high yield stems. Some important facts from the question is that the patient presented with watery diarrhea. The patient have a prior left leg abscess, and the patient went under oral clindamycin. The patient was also treated for have been treated for several years for gastroesophageal reflux disease with omeprazole. We have a proton pump inhibitor in here, and we have in here the EAI confirmed diagnosis. So this question is practically is screaming at us a C. difficile infection. But as you know, the question for the USMLE, and this is something I has always made that was very difficult for me at the beginning, is that there are two steps or three ladders. Some questions. They are not straightforward. So in here we know that we have a C. difficile infection, but we need to know which is the treatment. And we have in here ciprofloxacin, B, C, D, E, and the correct answer in here is fidaxomicin. That's the correct answer. We know that this is like regular standard treatment for C. difficile infection. So let's get into more details. So our learning objective in here, we have that the correct answer is answer C. We have the onset watery diarrhea. I explained more than 3 stools in the past 74 hours. That's watery diarrhea, low stools, abdominal pain, and low-grade fever. And this is the most important. This is what it's practically giving us the answer. Prior antimicrobial therapy with clindamycin, and this is highly suggestive for antibiotic colitis, also an AKA Clostridioides difficile infection, aka pseudomembranous colitis caused by C. difficile. So C. difficile colitis is also known as pseudomembranous colitis, what I was saying. So the diagnosis is established through a stool test of the Clostridium difficile toxin using the EAI that I explained, or it can even we can establish the diagnosis with positive identification of the Clostridium toxin gene using the nucleic acid amplification test. You know, we have the two tests that I explained to you before. The diagnosis can be done by these two, one of them, or we can send two of them just to be sure. Also, the preferred treatment for the initial episode of CDI is oral fidaxomicin, just as I explained. And why? Something that I didn't explain before, and I want to bring it on the table just to be clear. Why fidaxomicin and why not vancomycin? Why fidaxomicin is the first option, and why vancomycin is not? Well, fidaxomicin kills C. difficile, is bactericidal, and vanco inhibits the growth. It's bacteriostatic. So these are some general terms that we saw back in our micro general, and you see why it's very important, so that you can understand what fidaxomicin is the very first option in here. So also fidaxomicin has a narrower antimicrobial spectrum than vanco. Vanco has a very wide antimicrobial spectrum. So the important organisms of the Bacteroides group in the fecal flora are preserved by maintaining colonization resistance. So you know that the patient is already under a difficile infection, and we do not want to get rid of the Bacteroides group in the fecal flora. And since fidaxomicin has a narrowest antimicrobial spectrum, we can conserve this. So which prevents the introduction of or persistence of the pathogens, so the emergence of Clostridium difficile is inhibited. We have Option A, Cipro, is a fluoroquinolone, and as I explained, this is highly associated with the development of the disease. We have option B, tetracyclines, which are not indicated for CDI. We have option D, erythro, which is not used for C. difficile, and which is a macrolide, and fidaxomicin, which is a macrolide itself, is the first line for CDI infection. And finally, option E, dimethoprim, is not used for CDI, for C. difficile infection, but it has been implicated with the development of C. difficile. So yeah, this was a very cool question. I think that I'm going to be uploading a question for every video, because this is a way of active recall, active learning, and this is the key for the USMLE Step 1, active learning, active recall. So yeah, I hope that this video was very useful for you guys. We already got Clostridium difficile, and I'm going to be uploading the next videos for Perfinges tetani and botulinum. Yeah, I will appreciate you to subscribe to my channel, give thumbs up, and that's it. See you later.